Good afternoon, everyone. First, I'd like to thank the organizing committee and especially Morale for the kind invitation to present our rather provocative data on aortic root widening, blood pressure, and endothelial function. So basically, I'm an associate professor. I'm also a vascular pharmacologist, vascular biologist, and I study drugs in various disease models. And normally, I do not have a disclosure slide, but I have to mention that we have a research contract with Novartis. It is not directly related to Marfan Syndrome, but just basically just to make sure, feel free to take what I say with a grain of salt. So I'm basically part of the Vancouver Marfan Research Group, and this is a really fantastic team of cardiac surgeons, cardiologists, and also basic scientists and basic pharmacologists that are interested in studying how drugs tend to modulate the biophysical properties of the aorta in connective tissue diseases, especially in Marfan Syndrome. As Dr. Dietz so elegantly mentioned in the previous lecture, when it comes to the management of these patients with Marfan syndrome, they're generally managed with either losartan or a Tylenol. And from a mechanistic perspective, it is believed that losartan blocks the ATR1 receptor, and by doing this, reduces afterload, reduces TGF-beta signaling, whereas ACE inhibitors that block the conversion of angiotensin 1 and angiotensin into angiotensin 2, they basically block both receptors, including the ATR2 receptor that is believed to be protective in Marfan syndrome. And this is basically explained why ACE inhibitors have gained very little traction in management of these patients. So I've been working on receptors in different settings for 2 decades now, and these switch going from one receptor to the other, in my book, they have always been far more complex than initially believed. So this is where my lab comes in handy, where I have a lot of knowledge when it comes to the generation of advanced transgenics. We've basically been using the perfect Marfan patients. This is the C1039G fibrillin deficient mouse from the Dietz laboratory. I say the perfect patients because, yes, they tend to stink a little bit. They have a tail, which freaks some people out there. But they're very compliant. We force them to take their medications so they don't complain. And also, if something happens, you don't need to talk to the family, which is really awesome in our settings. But basically, no, they're a perfect model because they have basically the aortic pathology, they have a mild emphysematous phenotype, and they also develop kyphoscoliosis. And what we did in those experiments, we've basically designed a Marfan mouse that in theory should be protected against Marfan syndrome, basically by removing the main receptor or the main bad guy of the pathology, the ATR1 receptor subtype A, which basically these mice have been shown previously to be non-responsive to angiotensin 2, and they also seem to be bradycardic, hypotensive. And basically, again, the hypothesis was that those mice would be a perfect model of the perfect protection against losartan treatment. As I just mentioned, they've been shown previously to have like very little response to angiotensin 2 infusion. They're bradycardic, hypotensive, and also they have the same body weight as wild-type mice. So we know we're comparing apples and apples here. And basically, they also have been shown to the ATR1A inactivation to correct the cardiac size and dysfunction in the fibrillin MGR model of Marfan syndrome. So we knew we were in good hands when we developed those mice. And first thing we look at kyphoscoliosis by X-ray, and it was really obvious that we did not prevent the kyphoscoliosis in those mice by removing the TR1 receptor. Again, we knew those mice would be protected against Marfan syndrome, but not the kyphoscoliosis that we were expecting. But things got quite a bit more complex, and when we started looking at the aortic root widening in those mice, as I told you, they're hypotensive, they're bradycardic, we did their genotyping, everything is super clean. But if you look at the medial thickening and the elastic fiber fragmentation in the mice that don't have the TR1A receptor, they're pretty much similar to the Marfan mice. Look, for instance, this is like the medial thickening of a wild-type mouse. We can do some echo of those mice, as mentioned by Dr. Dietz earlier. And when we look at the aortic root widening in those mice, there was no inhibition. So instead of having a mouse that was protected against at least a vascular manifestation of Marfan syndrome, we got pretty much the opposite. There's simply no protection. So I told my student who was working on this project, I told her, I'm very sorry, this is not looking like it's going to work out. But no, I mean, we kept digging, and this was another experiment that Stephanie Sellers in my lab did. She basically treated those mice with losartan and looked for aortic widening. We're using the 0.7 mild dose of losartan for all our experiments. And look at this, the mice that don't have the target of losartan, the ATR1 receptor, responded to losartan just the same. So basically this kind of mixed everything up even more. We were really confused by these data, but I mean, I tell my undergrad students, my grad students, and my medical students, from a pharmacological perspective, if you don't have the target of the drug should be inactive at the dose you're using it at, unless you're in the presence of very important off-target effects. So we looked at the literature. I'm going to try to make a long story short here, but there was some evidence that losartan can indeed activate the nitric oxide synthase pathway, or the endothelial function pathway. Endothelial function being the release from the endothelium of, for instance, nitric oxide from an NO synthase, prostacyclin, and also EDHF to cause smooth muscle cell vasodilation. I knew that was going to happen during my presentation as well. So basically, an easy way to visualize endothelial function is if you take a patient and you submit it to a stress test. Some patients have a massive increase in blood pressure, some don't. Well, those who tend to have a massive increase in blood pressure tend to have more endothelial dysfunction. So this really is a way for vessel to compensate for an increase in flow, for instance, by promoting vasodilation through the release of all those mediators. And there are papers out there that show that NO is a really good inhibitor of TGF-beta signaling. So we said, this could be a possibility, right? What we did is that we pre-treated our Marfan mice with L-NAME, which is a nitric oxide synthase inhibitor, so it blocks all the NOS isoforms out there. There are 3, but it blocks them all. And we basically try to look for aortic widening in the treatment with losartan. So, for instance, this is inhibition of aortic widening with losartan, but if the mice are pretreated with L-NAME, so if you block nitric oxide synthases in those animals, well, finally we were able to block the anti-aortic root widening effects of losartan. So we said, then finally we're headed somewhere here. And what we did 4 different approaches from what I remember. We basically got mice from Paul Wong at Harvard that overexpressed the endothelial nitric oxide synthase. It's the main eNOS isoform that is responsible for nitric oxide release for endothelial function, for flow-mediated dilation. We had 3 mice for this. I'm just showing you 2 data here, 2 sets of data. We have the constitutively active or phosphomutant eNOS mouse. This is from Paul Wong at Harvard. And these are eNOS overexpressor mice. They basically just have more eNOS. These mice are from Heritable in the Netherlands. And as you can see, they basically inhibit aortic widening by around 40–50%, which is what we expected with a mild dose of losartan. And basically, this suggested that really endothelial function, I've been working on endothelial function for a while, and it's kind of a black box. We don't really understand it very well. But what this basically suggested is that when it comes to blood pressure lowering and bradycardia, at least in the mouse model, we noticed that there's a very little therapeutic value in lowering blood pressure with either the loss of ATR1 or losartan, basically. And in fact, this is controversial, but our data suggests that maybe the Ang2-ATR1 signaling axis might be of minor or less important contribution to aortic root widening in those Marfan mice. And all of a sudden, the fact that ACE inhibitors don't really work in those patients takes a whole new meaning. Is it possible, basically, that the Ang2 signaling system plays much less of a role in those animals than initially believed? Instead, we think that it's a matter of endothelial function. Somehow the amount of nitric oxide that the vessels can release, for instance, might be of greater importance to the management of those patients. So it basically highlights the role of endothelial function in the response to losartan, for instance. And just to build an even more case around the importance of endothelial function in Marfan patient management, or at least in our mouse model here, basically, a colleague of mine, Mitra Esfandiari, who is now in Arizona, she basically took Marfan mice. You basically can see here the medial thickening and elastic fiber fragmentation, and she force exercised them, basically. And you can see after 6 months that the aortic widening, the elastic fiber fragmentation and the medial thickening is mostly gone in those mice. And what is the best, the most ubiquitous activator of endothelial function? Well, it is aerobic exercise. So it's another basically piece of the puzzle that suggests that endothelial function might be of high relevance when it comes to the management of our patients. Moving forward now, how can our patients benefit from these findings? Well, there are some papers out there that show that Marfan patients have some kind of an unusual kind of endothelial dysfunction. And I really stress this here, selective impairment of flow-mediated dilation. So there's a classic experiment that basically allows the measurement of flow-mediated dilation. You basically inflate a cuff in a patient with an echo probe, and you can basically determine how you restore, when you restore flow, that there's going to be a flow-mediated dilation of the brachial artery in the system, and this is a marker of endothelial function. Well, Marfan patients are known to be at least defective in some aspects of flow-mediated dilation. And one of the cool things is that the Marfan Research Group in Vancouver, they have been studying patients on Tylenol and losartan when it comes to blood pressure lowering effects and also flow-mediated dilation. And because of our data that basically links the effect of losartan on flow-mediated dilation, we look at retrospectively at some patients that have been on losartan. Some of them we knew we had their flow-mediated dilation score before the start of losartan treatment and after the start of losartan treatment. And it was quite surprising, and even it was rather obvious, even if we had a rather low number of patients, is that in patients that have a low increase or no increase in flow-mediated dilation, all these patients basically had a mild or moderate increase in aortic root widening over the course of a year. But all patients who had an increase in flow-mediated dilation in response to losartan, they basically all showed a regression of aortic root widening, which was a little unexpected. But at the same time, this is where most of our data point towards an increase in flow-mediated dilation or an increase in endothelial function might be of therapeutic significance in those patients. This is data that we've obtained recently in the lab. We noticed that all those ARBs, those angiotensin receptor blockers, they're all structurally similar. And so we decided to test whether it was possible that some of those ARBs have those off-target anti-remodeling effects, but they differ in terms of efficacy. What we did basically is that we took 3 ARBs that have previously been linked to endothelial function activation, losartan again, which is our positive control, but we also included telmisartan and valsartan, and this is the disclosure I had for you earlier. We used basically valsartan at a dose for a contract with Novartis as a concentration at a dose that does not lower blood pressure, but look at aortic widening. Even in absence of blood pressure lowering effect with valsartan, we inhibit aortic widening just as well as losartan. So we think that we're kind of unrevealing like a very unexpected biological significance of those angiotensin receptor blockers in our mouse models. Of course, these are mice, so there might be a difference when it comes to the translation to patients. But what I'm trying to say here is that no, don't stop prescribing Tylenol or losartan for your patients. But one thing that might be important here is a dose. Is it possible that a lot of the negative clinical trials around ARBs, for instance, is it because the dose was not sufficient enough, high enough to increase endothelial function activation? That's something that is worth discussing. I'm showing you here the data on telmisartan, but it's the same thing for valsartan. This is, for instance, the constriction of a aortic ring of a normal mouse. Of a normal mouse in response to phenylephrine, so constriction, less constriction of a Marfan mouse. But look at what happens when you treat those mice with telmisartan. There's simply very little constriction of those aortic tissues in response to phenylephrine. If you block NO, you block this entire response. So we know those ARBs are very, very effective at increasing endothelial function. I've been working on endothelial function for 20 years. I've never seen a drug that can activate endothelial function to a certain extent, especially in vivo. How about blood pressure lowering? Well, yes, the hemodynamic, it's counterintuitive to suggest that maybe blood lowering might be of lower therapeutic value than initially believed, but again, this is what our data suggests, so feel free to take these nonetheless with a grain of salt. Instead, we think that flow-metered dilation might be useful for the titration of, for instance, losartan or their other ARBs for the management of Marfan patients. One thing I'd like to say here, and this is one of the take-home messages, is that when it comes to ARBs and Marfan aortic root management, we don't think that they're all created equal. They seem to have a very heterogeneous effect when it comes to inhibition of aortic root widening. Telmisartan, valsartan are really good when it comes to inhibition of aortic root. Valsartan seems to do it without lowering blood pressure. In fact, there's one paper out there from 2000 that suggests that indeed valsartan has some anti-aneurysm effect without lowering blood pressure, so we know we're not alone in preaching with this message. In fact, irbesartan, as Dr. Dietz mentioned earlier, has been shown to slow the rate of aortic root dilation. We've never tried it in our system, but another ARB that we've tested in our system is olmesartan. Olmesartan seems to have very low bang for buck when it comes to inhibition of aortic root widening. We don't really understand why. The effect on endothelial function activation seems to be less than telmisartan and valsartan. Well, now, the cool thing is that if we can attenuate the aortic widening, for instance, with valsartan without lowering blood pressure, but we think that we might have a case to have better compliance with our patients. If they're not as tired, if they're not as affected by the medications, yet they are protected, we think that they might be more compliant and also increase the quality of life. And more, our clinic is preaching the mild aerobic exercise message, is that basically if you increase endothelial function, you might have a little increase in blood pressure while you exercise, but then if you only exercise for an hour, then you get 23 hours during the day where you have an increase in endothelial function and your tissues might be protected. So we're saying basically now to our patients, just go for a long walk, 30-minute, an hour a day walk, just to get that endothelial function going. And if I've interested you in our data, well, we'd like also to go prospective with this. We think that managing patients with valsartan, if you titrate it against blood pressure lowering, for instance, with valsartan, we think that if you lower blood pressure with valsartan, you're way, way within the endothelial function activation range with certain ARBs, including valsartan. Losartan seems to be an average activator of endothelial function. So if you're interested, just contact us. We'd like to go prospective with this, and we think there might be no risk to our patients because, again, we're using an ARB for their management. So a big thank you. This is my lab. I'd like to thank especially Stephanie Sellers for her work, our funding agencies, and also the Vancouver Marfan Research Group for stimulating ideas and stimulating discussion. I'm happy to take any questions you guys may have. And thank you for your attention.
Thanks so much, Pascal, for a really interesting talk. We have time for a couple of questions, and Hal is approaching the microphone.
Oh.
Hi.
So I find your work fascinating.
Thank you. I wasn't sure what you were going to say.
No. I mean, as you can imagine, also puzzling. So, we don't have a receptor for this off-target effect. In our now extensive titration experiments, it behaves like a saturable, phenomenon. The factor that's not being adequately considered, I know that there were some sort of cursory controls, but as you know, there's an AT1B receptor. We've now done experiments knocking out AT1 and have direct evidence that there is tremendous compensation with upregulation of the AT1B receptor. Hiromi Yanagisawa has found the same thing. So, I mean, it would be something that would reconcile various aspects of your observations and our observations, and I really do believe that that is a critical control. There was work published in Nature Medicine in 2017 that you're probably aware of, the NOS2 inhibitor. And there were some rather striking but magical observations that, within 7 days of starting the NOS2 inhibitor, the aortic size had shrunk back down to normal, and supposedly the aortic wall had fully remodeled, and there was normal elastic fiber architecture within 7 days. I mean, it's just so, it's almost not plausible that some of those effects could occur within that time frame. So, I think that there's lots of mystery remaining to be explained, but I don't think there's going to be an easy answer.
Yeah, your point is very well taken, especially when it comes to NOS2. We tried to make the alpha-beta triple mouse in the context of the C1039G mice, and they were simply they were not viable. We tried our best; there was no way to do it. But one thing is sure is that those ARBs, even in wild-type mice, they are extremely active from an anti-remodeling perspective. Even in absence of ATR1, complete absence, they're still active.
I'm sorry, I'm not sure I understood.
In absence of ATR1 receptors.
A and B?
Yes.
And what are you saying is very responsive?
Some of them are responsive to, basically the alpha-beta double knockout is responsive to ARBs.
And is there any sense?
No, we're not looking at aortic widening.
Yeah. Is there any sense of mechanism?
Yes, we think we have a receptor. We're not sure, we're trying to confirm it, but we're on the path of something. In fact, Johns Hopkins is also studying losartan or ARBs in chronic COPD patients. There's a lot of endothelial dysfunction in those patients. So it all, again, points towards endothelial function. The simple explanation is that they activate endothelial function, and then you downregulate TGF-beta signaling. That's a simple explanation. It most likely is going to be more complex than that.
So how does that happen? How does an event in the endothelium have a consequence deep within the aortic media with intervening elastic lamellae? Again, getting from point A to point B it's a difficult road to travel.
Endothelial function is a black box. I agree with you. Exercise is a black box. Everybody knows it's good. Nobody does it enough. That's just the way it is. What was I going to say? We'd like to exercise mice, eNOS knockout mice, and see basically what aspect of exercise is eNOS nitric oxide driven. That's something we'd like to explore in the future. But you're right. It's complicated.
Have you tried knocking out eNOS?
eNOS, yes.
In these mice?
We were not able to do it, but supposedly the Spanish group did another kind of breeding scheme, and they managed to do it.
And was that dramatically protected?
I can't remember if they have data or they've just done it. It was at the Amsterdam meeting, but they mentioned they were able to do it. Thank you.
We've time for maybe one more quick question. I could ask a question,
sure.
If that's okay, Pascal.
Absolutely.
So I'm interested in your observations on flow-mediated dilatation in Marfan being impaired. Is there an interaction with age?
Good. Well, in theory, in the population, the older you get, the more likely you are to suffer from endothelial dysfunction. I'm not sure if there's some data out there. The cardiologist from Houston, I can't remember her name. Yes, do you have data on what? It's a very valid question whether Marfan patients are at greater risk of developing endothelial dysfunction earlier. They are, but whether.
I was just wondering, does it turn it into an old person response, or does Marfan go beyond that? Don't know. Interesting.
What would be really interesting, actually, is to follow these patients with a portable blood pressure monitor while they exercise. For instance, they go for a 1 hour walk, and you can basically tell how much their blood pressure goes up And then you can tell how much endothelial dysfunction they have without measuring endothelial dysfunction or measuring endothelial function, and see with chronic training or chronic exercise whether their blood pressure response becomes more and more minor with exercise, which would suggest that they have less of an endothelial dysfunction-like phenotype.
Thanks so much, Pascal.